Hello, good morning.
Hey, good morning, everyone.
This is our new time, Mondays at 9 a.m.
Yeah, it's a good way to start the week, I think.
I think so.
Start on a high note with our Instagram Live. It's a good way to combat the Sunday scaries, too.
That's true.
Yeah.
So today we are going to talk about weight and fertility and Ozempic, because this is something that you guys asked about, and it's been all over social media. So we figure we'll tackle it today.
Yeah. This has been, I think weight is always a big issue, and it's always something people are talking about, but I think especially now weight and fertility and this whole Ozempic babies thing has popped up everywhere. I mean, I think, on the news and newspapers, magazines, social media. I remember my mom even called me about it one time. She's like, what are these Ozempic babies? Tell me more about this. I'm curious. So I think, it's time for us to tackle it. Yeah.
So it's definitely trending everywhere. There was an article in USA Today, and Yahoo, and even Global News did a segment on it. So Ozempic, as many of you know, is a weight loss medication. It is a GLP-1 agonist, and it's prescribed in people who have type 2 diabetes and obesity in order to help them lose weight. And from what I understand, it's very, very effective. We don't prescribe it because that's not our area of expertise, but I certainly have lots of patients that have tried it for weight loss, and my understanding is that it's very, very effective with weight loss. So there have been lots of people saying, hey, I'm on Ozempic and I got pregnant and I wasn't even trying to. It's annoying to begin with, but whatever. Let's just not go there.
Yeah.
So that's where the term Ozempic baby came from all of these surprise pregnancies in people who were taking Ozempic and were trying to conceive and had spontaneous pregnancies that they were not expecting. I've had actually some fertility patients who were on Ozempic for weight loss, for fertility, and they also did get surprise spontaneous pregnancies. So that was nice.
Amazing.
Yeah.
I don't think I've had patients on Ozempic, but I don't think any of them have gotten pregnant spontaneously that I can think of. Yeah.
I have one. I shouldn't say lots. I have one like that. Yeah. So why is this happening? Well, for one thing, there's some mechanism we don't really understand. It's a fairly new medication, so we don't know if Ozempic itself is doing something on the level of the uterine lining or on the level of the ovary. That hasn't really been described. But there are two ways in which we think this is happening. One is women that have polycystic ovarian syndrome. We talked about it the last Instagram Live. Sometimes if you have polycystic ovarian syndrome and irregular cycles, and you happen to lose some weight, 5-10% of your body weight, then you could resume a spontaneous ovulation. So let's say there is somebody who wasn't trying to conceive, having very irregular cycles, high BMI, polycystic ovarian syndrome. They take Ozempic, they lose 20 pounds, and all of a sudden they get a period out of the blue. And if they were not used to that, or they were not using any other method of contraception, then that's where some of those spontaneous pregnancies can come from the weight loss that induces ovulation in women with high BMI and polycystic ovarian syndrome.
The other thing is that Ozempic, it's a medication that delays gastric emptying. That's how it works to help people feel fuller longer. So the food just kind of sits in the stomach before it goes into the intestine. So your stomach feels fuller for longer, so then people are eating less. And along with that can affect the absorption of medications. So something like the birth control pill or the oral contraceptive pill, in a medication where it delays gastric emptying, is probably less effective. And so again, that's another reason why people can conceive spontaneously, even when they were actively contracepting or actively preventing pregnancy. The other thing that can sometimes happen, and it's always worth mentioning, is that in situations where you, let's say, have a gastrointestinal illness, so if you're having nausea, vomiting, that can also affect the effectiveness of the birth control pill in general. So for patients who are on a birth control pill and who have vomiting, let's say a viral stomach bug or something like that, we do recommend backup contraception just in general. But again, we know that Ozempic has some of the side effects of Ozempic can include those kind of GI upset type symptoms. And so when you add that on top of, birth control pill, on top of, more regular ovulation, for some patients, that can mean spontaneous pregnancies that were not maybe intentional. Yeah.
Now, it's important to know that the manufacturers of these medications did not include pregnant people in their studies, so we really don't know what is the impact of these medications in early pregnancy. So whenever we hear of somebody who got pregnant on Ozempic, we want them to stop it right away. When the medications first came in the market, there was a concern about what happens if you had a spontaneous conception on it, and people were saying, well, 2 months washout period to make sure that the medication is completely out of the system before pregnancy, because again, we just don't know what it does in early pregnancy. So in the real world, these Ozempic babies, as far as we know, have been fine. So far they haven't described any concerns, but this is not enough evidence to say you can be on Ozempic when you're pregnant, or you shouldn't worry about stopping Ozempic in an early pregnancy. It's still very much recommended not to get pregnant while on Ozempic. For patients who are going through IVF, this is a bit controversial. Everybody does something a little different because we just don't know. But I feel comfortable having my patients on Ozempic up until the time they start their IVF stimulation, because usually for an IVF stimulation, we're retrieving the eggs and making embryos. We're not making a pregnancy right in that cycle. So in those situations, I'm comfortable with them being on it right up until the moment they start their injections, and we stop the Ozempic. They have a whole month to make those embryos, and then another month for embryo transfer. So they will be off for about 2 to 3 months prior to actually establishing a pregnancy. But and this can get into the next topic about weight on IVF, but if it's being effective and they are losing their weight and it's going to make their IVF cycle more successful for that reason, then I do want them on it right until that time, because we do know that when you stop the medication, sometimes the weight can come back.
Yeah. I mean, there's really no great, as you said, guidelines or evidence to follow. The challenge always is with any medication, whenever it comes out, it's never tested in pregnant people, and the implications on fertility don't get thought about or tested for many, many, many years, if they ever do. And so, it's always challenging where we're kind of working in a real vacuum of information and evidence when we're talking about Ozempic. But I agree. I mean, I think stopping at either the cycle before you're going to start your stim or the cycle of stim, depending on kind of what the bigger plan is reasonable. And you're right, people are on Ozempic for a reason. So if you're on it because you're managing blood sugars, like, you have to have a backup plan in terms of like, what are you going to do to keep those blood sugars under control? Because we know that is also super important when it comes to early pregnancy, or again, if it's for weight loss. As soon as people stop it, many of them do gain back some weight, and so it's really about kind of the balancing of those two things.
Absolutely. So that brings us into the next topic, which is weight and fertility. Should we tackle that one?
I mean, I think we should. We absolutely do need to. I will admit, this is always something that it's a hard topic to talk about. It's a really, really hard topic to talk about, and I think it's something that we want to do in a way that is, evidence-based, that provides that's truthful, that's evidence-based, but it's also compassionate and inclusive. And like, it's a really difficult topic to talk about for everyone. And I mean, we even like myself, I have my own biases and I have my own feelings about weight, etc., that come into my brain at any time, right? And so it's always trying to navigate, sort of work through all of those things to present a balanced view. It's hard.
Yeah. Weight bias in medicine is, it exists. Anybody who denies it, they really have their head in the sand. It has been studied, it has been published, it's out there. And I think physicians need to be honest with themselves and recognize that it's there, that it exists, and what can we do to mitigate that. So that's something that's always in the front of my mind as well. So we know that in medicine we use BMI, with the body mass index, to classify people based on weight and therefore make some decisions about the risk of different treatments. The body mass index is a combination of weight and height, and we know that it is an imperfect measurement of health. Everybody knows that. Unfortunately, it is the best measurement that we have, and all the studies that talk about weight and fertility use BMI as a marker to determine when the risk of IVF or pregnancy or miscarriages increases. They use BMIs to determine that. So for me, I can't really say we're gonna completely ignore the BMI, because that wouldn't really be fair to our patients, and it would actually put patients at risk. And we're gonna talk about the risks at some point. But for me, when I meet a patient, I have to always document what's your height, what's your weight for every single patient, regardless of whether it's 20 or 40. We always have to document that as part of our history, just like we document everything else. And then if I am concerned that the BMI is a little high, then we talk. Then I ask them, what is this way high for you? Is it low for you? Are you losing? Are you gaining? What are your eating patterns? What are your movement patterns? How do you feel about this weight? What do you think? And patients know. Sometimes I've had patients to tell me, this is my weight. I'm healthy. I move every day. I exercise. This is my body the way it is. I've always had this weight for the last 20 years. And then that's great. Like, I'm happy to know that. And if that BMI is like 38 or 40 or 41, and they tell me this is the way my body looks, and these are my I don't smoke, I don't drink excessively, I go for walks every day, I have like a normal sort of healthy life, then that's the end of that conversation, as long as the BMI is under 45, and that's that. Sometimes patients are like, no, I'm really struggling. I've gained 20 pounds in the last 3 months. I'm eating terribly. I'm drinking too much, or I barely move because I'm so stressed. Then that's worth a conversation and figuring out how we can do better from that point of view. So we know that BMI is imperfect. I wish there was a better marker. I'm sure that like metabolic health would be a better marker of outcomes of BMI and fertility. Unfortunately, there is no way to really describe metabolic health. I mean, you can look at blood sugar, you can look at hemoglobin A1C, you can look at blood pressure, you can look at cholesterol levels, abdominal circumference ratio. All of these things have been talked about to describe metabolic health, but there isn't like a really good measurement that you can just do on somebody and be like healthy and unhealthy. So that's why BMI is what's being used currently as a surrogate marker for health, which is a very imperfect one.
Absolutely. And I think for myself, so I also, patients who are coming through, I'll always ask about height, weight, because it's an important point for us to know, just like we ask about medications and allergies to certain medications. Even if, I may not necessarily be giving you that drug, it's still important for us to document these things. One of the things that I think is also important is to counsel about some of the risks. So just like whenever we're seeing a patient, we're assessing sort of what the risks are for someone. And so weight is part of that. We also talk about age. We also talk about relation to other medical issues, medical comorbidities that somebody has. I will talk to patients sometimes about weight and pregnancy as well, for people who are planning pregnancy. I think as fertility doctors, we're kind of in a unique position where we have patients who are planning for pregnancy. We have that opportunity to sort of talk to people before they even get into pregnancy about what we can do to maximize the health of the pregnancy, the best outcomes in pregnancy, and the health of the baby. And so we know that weight also has some increased risk factors when it comes to pregnancy in and of itself. And so it's another opportunity to talk about things.
When it comes to weight and fertility, there are 3 main things to think about. Sorry, when I said fertility, I mean IVF specifically. So one is the impact of weight on the sedation that you need for having an egg retrieval. The other one is the impact of weight on the ability to access the ovaries to get all of those eggs. And the third one is the impact of weight on the reproductive outcome. That would be egg quality, embryo development, number of diploid embryos, implantation rate, and miscarriage rate. So we know that weight has an impact in all of those 3 things. From the point of view of the sedation, one of the concerns is airway management. So if somebody has sleep apnea, which sometimes people that have a high BMI can have, not everybody with a high BMI has sleep apnea, but that's certainly a big risk factor for the inability to be put to sleep, because you basically stop breathing. And also there could be issues with airway obstruction and then ability to back the patient when the BMI is elevated. So here in our clinic, we're lucky to have anesthesiologists that come from the hospital. So we're able to have a really high limit for BMI. Our limit is 45. For many other clinics, it's 38 or 40. So we're able to go higher, but we can go to BMIs of 50s or 60 because it's still not a hospital, this is a clinic.
Yeah.
And we need to make sure that patients can be safely sedated without needing intubation, because this is just not the place for that.
Yeah, and these numbers are not arbitrary. I think it's important to point out. So we are an out-of-hospital facility. Our clinic, although we are located next to the hospital, we're not physically on hospital property. And so the College of Physicians and Surgeons of Ontario is very clear and very specific in terms of what limit of BMI we can sedate in a clinic such as this. And so that's where that 45 number comes from. So we're very lucky that, as you said, that we have anesthesiologist presence. I mean, I always say that they're the experts in airway management. And so whenever there's any concerns about airway, who better to have than an anesthesiologist around? Certainly me, not you. We're only mildly helpful. The anesthesiologists are really the expert when it comes to airway. As far as I know, we have the highest BMI limit of any clinic in Canada that I know of. Now, I do know I can think of one clinic that does offer IVF egg retrievals for patients with higher BMIs. However, they do it without any sedation. So I think they may use just like an oral medication, like a benzodiazepine, like Ativan.
So the second issue with weight and IVF is access to the ovaries. To be clear, access to the ovaries can be an issue regardless of your BMI. I've had women with BMIs of 25 and they might have a big fibroid and the ovaries are still like high up here, covered by bowel, and you can't get them. So it's not something that is specific to high BMIs, but certainly you can have more issues with high BMI because it's just more difficult to see them. It might be very difficult to bring them down, like to put pressure in the abdomen to bring them down. So sometimes when I'm first assessing a patient with a higher BMI, that's one of the things that I wanted to look at before we even get to the egg retrieval part is, are the ovaries accessible? And then if they are, sometimes they change at the time of the egg retrieval. And again, the abdominal wall and the bowel and the position and the difficulty seeing them can't really make it unsafe to be able to get all the eggs that we want to get.
Yeah, I think this is a point that's really important to highlight. And again, this is not just a function of BMI, but it's really, really difficult to predict how well you're going to be able to access the ovaries at the time of egg retrieval, because when the ovaries are not stimulated, you may have one follicle growing and the ovaries tend to sit a little bit higher, and again, when somebody's having just a regular transvaginal scan, you're not going to be pushing sort of either the vaginal probe or with the abdominal wall that much, because it can be very uncomfortable to be able to really see how mobile or how much movement you can get out of the ovary. A lot of the times, like, you don't really know until you get to the retrieval itself in terms of how accessible the ovaries and the follicles are going to be. And that's a really, really, really tough one where, we do our best, and we're lucky because we have, patients who are comfortable because they're asleep. So we can push a little bit more either on their tummy or push a little bit more transvaginally with the probe to get to the ovaries. We have another person, the ultrasound tech is there in the room, who can help us, push the ovary, help us sort of move things around as needed. We do transabdominal retrievals. Again, not all clinics do. So what I mean by that is typically a egg retrieval is done with the ultrasound probe in the vagina. There's a needle on the end of it, and we're able to access the ovaries via the back vaginal wall. We do transabdominal retrievals as well, meaning that we would actually use the ultrasound probe in the tummy through the abdominal wall to access the ovaries as well. Sometimes that can be an option, but again, the bowels are in constant movement. If there's more gas, less gas, bowels less full, more full, these will all play a role in how easy or how difficult we're able to get to the ovaries. And at the end of the day, the number one goal is to keep the patient safe. The secondary goal is to get as many eggs as possible.
And then the last part about high BMI and IVF outcomes is the quality of the eggs, the quality of the embryos. And this is a tricky one because honestly, you can see such variation when it comes to that. As a matter of fact, here at MFC, we published a study that was a poster at the CFAS, the last CFAS in Toronto in 2023, looking at a comparison group about women that had BMI over 43 and women that had like a lower BMI, and we saw that they both have really good pregnancy rates. Both groups had really good euploid rates. The main difference was a higher miscarriage rate in the higher BMI group, but we certainly had lots of really healthy pregnancies from the group of BMI over 43.
Mm-hmm.
So the whole question about like egg quality and embryo quality and euploid embryos and implantation, that is actually very controversial in the literature. And in my personal experience, I've seen a wide variation from like higher BMIs of 43 or 45 making like 6 euploid embryos and pregnancies with each of them versus the other extreme of like poor egg quality, poor fertilization, and poor embryo development, which is why I am convinced that it's not the weight, it's something else. It's the metabolic health, it's inflammation, it's age, it's it's genetics, it's lifestyle. There's so many other things that really play a role, and I wish that we could I wish that we could design a study that takes a group of women with high BMI and then dissect all of these things to really see what is the issue. It's probably not the BMI, it's something else.
Mm-hmm. Yeah, so when I was a fellow, I wrote a textbook chapter about obesity and fertility. The book is somewhere here. Oh, this one. Pregnancy and obesity. Anyway, so I wrote a textbook chapter specifically about obesity and fertility treatments. And you're right, the literature is so mixed.
Now, to be perfectly clear, I don't care how high your BMI is, a fertility doctor should see you. Like, this is something that I'm really getting angry about, because I have so many patients who tell me they wouldn't even see me, they wouldn't even talk to me, they wouldn't even do an investigations. For all we know, the problem is the sperm. For all we know, it's it's ovulation induction. Like, so I think this whole of like my BMI is too high, therefore the clinic wouldn't even see me is total BS. That's wrong. Second of all, we're talking about IVF here. IUI is an option.
Absolutely.
Time intercourse is an option. Ovulation induction is an option. Metformin is an option if you have PCOS. So there are fertility treatment options for women with higher BMI. So absolutely, it's not right that sometimes I hear stories of patients that tell me they looked at me and told me to go away. They wouldn't even do the testing, or they wouldn't even talk about other options because of my BMI, and that is absolutely total BS. And the other thing I would say is that BMI is not a consideration or part of the criteria for Ontario funded IVF cycles. Your particular clinic might say, our BMI is 38 and therefore because you're 40 we cannot do you here, which is not the same as you cannot have a funded IVF cycle somewhere else. Okay, so that's another type of consult that I get, where patient says, they told me I just wasn't a candidate for funded IVF, period. Which would be incorrect based on BMI. Again, your clinic may decide what criteria they use to do IVS, and that's up to them, but that has nothing to do with the Ontario funded program. So if there's another clinic that can do it and can offer the funded, then you can certainly do that. Regardless of your weight, regardless of your goal, you should never feel shamed by your fertility specialist. You shouldn't feel shamed by anyone, but particularly not your fertility specialist. And again, that's also something that some patients have told me about, which really upsets me. Like, I mean, sometimes we do have to say it, we do have to talk about it, because we want the best thing for you and your pregnancy outcomes, but it should be a conversation where you feel heard and supported, not a conversation where you feel shamed and you're being told, go and lose weight and then come back. I have nothing to offer, I have nothing to talk about until you've lost weight. There's that's just not right.